Hi, Tori. Can you hear me?
Perfect. Yes.
All right, thank you. Hello, everyone. Thank you very much for attending the webinar tonight. We're very honored to have you. I'd like to introduce our speaker for tonight, Dr. Lon McRae. We're very fortunate to have him on here tonight. Dr. McRae graduated from the Oregon Health Sciences University School of Dentistry in 1996 and has had a very successful practice since then in Meridian, Idaho. In 2000, Dr. McRae received an advanced degree from Pacific Aesthetic Continuum, one of the world's most respected cosmetic dentistry training programs. He's also taught aesthetic dentistry both nationally and internationally, as well as being an active speaker nationally and internationally. He has works published in many publications, including the Journal of the American Academy of Cosmetic Dentistry and Inside Dentistry. And I think one of the things that Dr. McRae is the most proud of is in partnership with the Crown Council and country music star Garth Brooks. Dr. McRae is a founding member of the Smiles for Life Foundation, an organization that benefits underprivileged and seriously ill children. And since 1998, the Smiles for Life Foundation has donated more than $33 million to children in need. He's also done many humanitarian mission trips around the world. So, Dr. McRae, we're honored to have you tonight, and thank you so much.
Thank you. It's a pleasure to be with you. So I'm going to go ahead and share my screen. Thank you, Brett. And we'll get started here. I've got a lot to present to you today. Okay. Let's see here. Okay, here we go. I thought this was pretty cool because I still haven't found what I'm looking for yet. Always trying to do better. I just want to thank Gibson Dental Arts. I just want to thank them for hosting this, and let's get started here. It's not letting me go forward. There we go. Okay, this is me. Who cares? You've already kind of went through that a little bit. This is my office. There's a lot going on in our office. We built this about 8 years ago. You can see McRae Dental. We've got
Dr. McRae, I'm so sorry to interrupt. We are not seeing your slide advanced. We are still stuck on the Gibson Dental designs.
Oh, let's see let me stop sharing. Thank you for interrupting.
Absolutely.
Let's try. Let me share again. Do you see it now?
We do, but I see it in presenter mode still, so not.
Okay, so let me start from that. Do you see that now?
We do.
Okay, so there's my office. I'm going to advance and tell me if you see the next slide. There's my team. Do you see that?
We do not. We are still stuck on your current slide.
Oh boy. Let's see here. I am not sure how to fix this. Would you have an idea?
Now when you have your presentation playing, so right now we see your slides to the left-hand side. We saw that you hit play and it kind of gets stuck on that one slide. On your end, are you seeing it as just one large presentation?
Let me just exit out of all the other things that were potentially up and running and see if that helps. Yeah. Okay. So let me see if my wife is going to try to. I've done this a million times. I've never had the problem with this before.
If you go to presentation.
Well, let's just try it now. Let's see here. What if I just advance it like that? Do you see that?
We do, yes.
Okay, worst case scenario, we'll do it like that. It would be better if it was like this. So you see my team? Here's my team. Very proud of them. Now, do you see the advancement of my family?
We do not. Nope, we're stuck on your team.
All right, we're just going to do it. We're going to do it.
I apologize.
We're going to wing our way through this. Okay, but you do see this if I just leave it in this mode.
We do, yes. So we can see you advancing through these.
All right, so this is my real team. very, very proud of them. Okay, here is, this is a picture I took in Oregon. This is what we do. We work on smiles, and I think it's pretty interesting. Boy, nothing's getting advanced though. Let's see here. Well, we'll just make the most of it. So if you look at, they did this study where they looked at baseball players and they looked at their smiles. Those that had a beaming smile lived the longest. And then you've got a slight smile, and with the slight smile, they lived about 4 years younger than them, maybe 5 years, and then no smile, they lived the least. So smile, it'll help you. It's for longevity. Okay, I'm going to try this. Do you see, will you answer me this? Do you see when the words that come up?
We do not. Now, I don't know if there's like arrows to hit or if it's just the enter. Now we see the words.
That's fine.
here.
We'll just leave it. It's fine. We'll just make it work. So we have 5 reasons we should laugh. Number 1 is it makes us more attractive. It releases endorphins, helps us prevent infection, boosts our immune system. And number 5, it actually helps us poop. It helps our digestion. I thought that was really interesting. So let's get into implants. And here, oh boy, this is really going to be difficult because okay, we'll just have to make this work. Here is Dr. Brandemark. I'm just going to tell you what I know from the slides because it's hard to be able to make this work. But he's the one who came up with the 2-stage of osseointegration in the bone. We know him as the father of implantology. And with the father of implantology, it is very well known that the majority of implants that are done is done in a 3-stage approach. And so let's go to that. And with this 3-stage approach, what that is you extract it, you wait 4 to 6 months, 3 to 6 months. Then you place the implant, you wait another 4 to 6 months, and then you put your abutment and crown. That takes anywhere between 8 and 12 months. So Dr. Brandemark's big thing is that we are to wait a minimum of 3 to 6 months to allow the bone to heal around the implant, and that is known as osseointegration. Stage 2 implants is where you basically immediate placement. And this is the way that I talk with patients. I talk to them about a stage 3, stage 2, and stage 1. Stage 2 is you extract, immediate placement. And this is being done more and more with immediate placement of implants, and that we do this routinely in our practice. But then you put a stock abutment, usually you wait 3 to 6 months, and then you put your abutment in your final crown. Usually that would be a screw retained crown. Stage 1 is where you would extract a tooth. You would then place an immediate implant, but then you would place a final abutment either day 1 or up to 10 days later. And we'll kind of go through that. Let's see if it will. Nope. Okay, so here's the 5 problems that we see when we do this immediate placement of implants. And I want you to tell me, will you please vocally tell me if you see the actual video? So let me play this.
You're not seeing anything playing now.
Nothing?
No, just the sort of ombre screen.
Okay. And go back. Well, that video is not going to work. I don't know. I don't know if it's going to help or not. Okay, it's okay. Well, we'll just go this way. So they did a study in 2023, and what that video was showing you is what happens to the bone. Average bone loss, the most significant changes that take place is in the first 6 months after tooth extraction, with an average bone resorption of 3.79. So roughly 4 millimeters between the buccal and the lingual area we're losing up to 4 millimeters and up to 1.24 millimeters vertically. So even if we place a tooth, why do we get so much bone loss? That is going to be one of the big questions. Why? What happens to the bone? Now, that the implant will definitely hold the bone, but we still get a tremendous amount of bone loss. Number two is we have an increased risk of infection. And that just takes place because of the oral cavity and the bacteria that can take place around it. Number three, primary stability challenges. And so if we look at this graph, should be known to most of us that place implants. It's a very famous what happens with osseointegration. Let's just say that we place an implant and we get close to 100 Newton centimeters of torque. What happens is that we know that the osteoclast will go in and it will turn the bone to mush around an implant. So our stability drops dramatically in the first month. And the most dangerous time is right at 1 month. So whether we're doing an all-on-4, we're doing an immediate placement, anything that can dislodge it, the worst is going to happen in that first month. Then we have what's called osteoblasts that start building bone around the implant, and that's where we get the osseointegration. And at 8 months is when, this is what Dr. Brandemark is saying, minimum is at 2 months, but really we're looking at 3 to 4 months to be able to get ideal osseointegration. The fourth issue is we have soft tissue management. When we place a tooth in an implant, immediate placement, we put a stock abutment on, what we end up is we have to take that stock abutment off. What the normal way of doing this is we take our stock abutment off, we place after it's healed, we then place a impression coping or a scan body. We then are going to take that out. Each time we do that, we're actually ripping the Sharpie fibers that are around that abutment, even if it's only in there for 15 minutes. All of us use the original abutment that we took out. We might clean it up with even Conceptus. We put that back in, and then we let it heal for anywhere between a week to 2 weeks, maybe 3 weeks, while the crown is being made. What happens is then we get new Sharpie fibers, hemidesmosome area that will attach to that abutment, but it's never going to be as strong as it was on the original. So they are estimating that it potentially we only get 4 or 5 rips, and each time that attachment is going to be less and less and become more and more fragile. So the strength is going to go way down. The number 5 is we just have higher risk of complications. So they looked at this study where they did a huge study, very large. They looked at over 500 implants, and what they basically found is this, is that with the study looked at 588 patients, and over 9 years, 48%, almost 50%, developed some significant peri-implantitis. So we know that that can lead to tremendous amount of problems down the road for patients. When we look at studies that look at the success rate of implants, especially from implant manufacturers, usually those studies are a year or less. When you look at 9 to 10 years, that's when you start to look at all of these complications. Now, what I'm going to show you is now these are really bad. And I look at some of these and I go, okay, I have no idea how some of this was even done. And these are just bad day for the dentist, the surgeon, whoever placed this. This one's really bad when it just drops right into the inferior alveolar nerve. This is a really bad day. That's a sinus lift that didn't go well. And I imagine that is either an ENT oral surgeon that's going to have to go after that one. This one is pretty interesting in the fact that it's servicing the patient pretty well. But boy, that must have been one hairy surgery to be able to perform. So I wanted to show you this, and this is the traditional way of doing things. you're letting everything heal. Then you're placing the implant on a shrunken, but especially buccally lingually, and the horizontal height of those implants. That's I just found off of the internet. And it brings me to one that I saw that I think is really interesting. Normally, I can go through each individual. For some reason, this is not letting me to play this. So we got to go through each one of these individually, starting up here. Do you see my cursor at least? Do you see that
Yes.
on your end? Okay, great. At least we can start there. So if we look at this, and I think this is really awesome of this Dr. Kim, he's an oral maxillofacial surgeon. If you look at this and go, okay, do we see any problems with this actually with this surgery? And you can go through the progression and it looks actually really good. It was done very well, placed in the bone very well, right at the crest. And you would go, okay, that looks like it's going to be very successful. But then 4 months later, this is what happens. Now, this can happen to any of us. And as we do implants, we don't always understand the reason why. And so he asked the question, what happened here? So the only thing I can see is that could it be a potential blood supply problem? And one of the things that I've really been working on is not doing what Dr. Kim did. The tissue truly is the issue. Anytime we can not disrupt the blood supply around the area. What I see here is a beautiful osteotomy and bone, but that's when we see all this white, that is going to be a desiccation of the area. Could that be a potential issue that Dr. Kim faced? It's always a potential, but the reality is we don't know why that failed. And it can happen to the best of us. When we look at tissue and we look at tissue of an implant compared to a natural tooth, a lot of times you'll hear people say it's the exact same, very similar amount of junctional epithelium. And we would also then on an implant, it would be known as the abutment connection. But the reality is when you really look at it, you have a strong attachment on a tooth on the left side. This is the implant. The implant itself is very fragile. And so when you're ripping this tissue and you're doing this on a regular basis, it becomes less and less fragile. This is a huge part of what we're talking about when we look at the strength of the tissue around, and if we can hold the tissue, it's going to be by far the best option for our patients. This just is not going to work, but basically what I'm showing you here, and I can't advance it. Normally what I ask is, where is that implant? And then I go through a series of photos. And when you look at this, what it is that actually is an implant in the knee, and it's in the kneecap. And so what I ask is how fast do we load an implant? That implant looks exactly like a dental implant, but it's actually in the knee. How fast are they actually getting that patient up and walking? Almost immediately. And this is what we know in medicine. Can we load implants in the jaw, and can we load them immediately? I went and kind of changed my mind when I heard Dr. Costa, who works in Dubai. He only sees really kind of billionaires and millionaires. And so everything he does is he finishes his cases in 1 week, which kind of got me to thinking. And this was probably, I don't know, 8 to 10 years ago. Again, when we look at this graph, there's a difference now. Dr. Costa says, hey, this is the normal. The no-go zone is at 1 month. Normally, we wait 2 months before we do anything. What if I can finish all the cases within 10 days? And so all of his cases, he has a lab in his office. He finishes every single case in 10 days or less. And that was 8 years ago. So going through this, we're looking at this one stage. What can be done? How can that be done? These are all one stage cases. This is 3+ years. What we're looking for is a platform switch with the bone growing over it. These are all titanium implants. Here is an all-on-4, all-on-6, whatever you want to call that. This is a ceramic implant, and it also works with ceramic. It just, we don't have that platform switch. So let's go into what I see as a potential issue with how we do immediate implants now. When we do immediate implants, I'm going to show you a KOL slides. KOL is key opinion leader. And this is from a dental an implant manufacturer. So when you look at these slides, what I want you to do is I'd like to be very critical of what we see. So let's just start. What I want you to try to pick out is, where is the implant? Really look at this and say to yourself, where do you see the dental implant in this smile photo? And I can't see any of the responses, so I'm just going to keep going off. But what I want you to do is I want literally just go through each tooth and tell me, where do you see the potential implant? Now let's look at each individual slide. So when we look at this, my question to you, usually when I'm speaking live, what the question is, do we see any issues with the actual extraction? And most people say, well, potentially we gummed up the gum tissue, but overall we kept the interdental bone in between the roots. That looks actually pretty good. So the extraction was pretty well done. We can see that they separated it. That looks pretty good. A lot of people think that that is too far mesial. I actually like the placement. I like to place it in the mesial area because I get really good stability, especially with the curvus spee on a lower molar. So this is tooth number 19. And I just want to just kind of show you that, how that was placed. Let's look at the bone and the bone quality around that. So they did the bone graft. How's that? How does that look in relationship to the extraction? And could that have been done any better? So in your mind, what do you think? Here is the sutures. Could they have used a membrane? The sutures are, I mean, top of the line sutures, PTFE. It looks like it was well done. Now let's look at the healing. And let's really look at the healing. And I want you to think to yourself, is this good healing? The majority of people say, absolutely, that looks great. We have a really good zone of attachment all the way around the implant. I would agree with that. All of that looks excellent. The healing itself looks like it did extremely well what the implant's supposed to do. Where do we see any problems at all? So in your mind, do you see any issues? And I want to just point out to you, here is papilla, here is papilla, and because of the way this was done, loss of papilla and huge loss of papilla. Also, when we look at this and we follow this, we have a loss of bone, and a very large defect of bone. Why did this take place? My contention is that because we used a stock abutment, the traditional way of doing things, we lost that 4 millimeters of bone from the buccal lingual, and we lost a height of papilla all the way around this area. Could we potentially, if we held the tissue, even in an area where there is no implant, would that hold this area and we wouldn't have a huge loss of bone and papilla? That's what we're going to investigate. Let's continue and we'll look at this. We look at the healing. That is absolutely beautiful in my opinion. Wonderful healing around this area. We look at how the lab is going to make that, and they have to make it to where as big as they possibly can to keep us out as much food as they possibly can. Excuse me. But when we look at it, they had to do like a little ovate ponic on this. Not ideal. Now we look at this and we can see that that's the way the crown was done. It's the shading is beautiful. And when we see it, that shading is matching perfectly with the existing teeth. I would say that that's really pretty. But what's not pretty is this loss of bone. And this is what we accept every day in implantology. Is there potentially a better way of looking at this or a better way of doing it? We see the actual implant. It's a beautiful implant, beautiful healing. And overall, this is going to service this patient most likely the rest of their life. What are they going to have though? They're going to have that loss of bone in this area. And then I think it's very interesting that they're showing that it needs a proxy brush to keep it clean. So that's the problem that we see when we do it the traditional way that our fathers have shown. What I did on the internet is I Googled successful dental implants. And this is what I saw over and over again. Exactly the same scenario, whether it was screw retained, whether it was cement retained. We end up in this same scenario with loss of papilla, and loss of bone. Now let's look at, here's another one. Again, successful implant. We end up with loss of bone, loss of papilla. And so that patient's again going to have some issues down the road. This one, same thing, loss of papilla, loss of bone. I'm going to skip a little bit because it's not going to play correctly videos, but let's just look at, is there a paradigm shift that is happening in the world of implants? My contention is that there is. I always get his name incorrect. I want to say Dr. Leviticus, but it's not Leviticus. It's something similar to that. And he came up with the zero bone loss technique. This is similar to the zero bone loss technique, but I think we've taken it one step further in our approach. We call this all-in implants. Why do we call it all-in? Is because it's everything that a surgeon is going to need to be successful. All the guides, everything for the patient that the patient potentially is going to need prior to going into surgery. So it's a pre-planning process that you do with a design team. That design team will go through basically do the entire surgery. And then you will meet with the design team, go through and be able to then you'll have a meeting with them. It takes, for each individual patient, I did 3 today, and the total took about 7 minutes to go through it. They do all the design. I then approve it. I then go into surgery with my team already knowing everything that needs to be ordered for that patient. And so we're going to go through this, and I'm going to do it hopefully in a kind of a systematic way. The way that I look at this though is it's the fingerprint concept. And I look at this as, and I found this fact about fingerprints. In fact, the likelihood of 2 people sharing identical fingerprints is estimated to be less than 1 in 64 billion. This means it would likely take more than 4 million years for 2 people with identical fingerprints to appear by chance in the Scotland Yard's fingerprint database. So we all know this. Our fingerprint is unique to us. Each finger is different as well. Well, the fingerprint concept also works for sockets. Each socket is its own fingerprint. And it's extremely important that we're able to take and have a duplicate of that exact socket. So there is no stock abutment that is going to fit the exact dimensions of the socket. With the zero bone loss technique, they've got plastic, composite, different areas that you can seal that socket. But if you pre-plan it, could you go into your case, into the surgery, with everything pre-planned? And this is what happens with the design team. They have a proprietary software that gives them the ability to be able to map the exact dimensions of the fingerprint of that socket. So then when we go into surgery, we are matching what God gave that patient originally, which is unique to each individual tooth and to each individual patient. So let me show you. This is what we consider a two-stage approach. This patient came in. It's actually my father. He was 90 years old when we did this. We did all of the scans. What you have to do is you send a CBCT, a scan, digital scan of the patient, and then the design team maps that out and sends me, in this case, we knew that we just wanted a custom healing abutment. Well, we took off the crown, had a major abscess underneath that tooth, didn't have a whole lot of bone. So we placed the implant, placed bone around it. Here's day 1 of surgery. This is what we got from the lab, along with the surgical guide. This is basically a custom healing abutment in the exact fingerprint of the socket of this patient, which is my father. This is after it healed. This is 3 months later, and you can see that it is fitting that tissue and sealing the tissue. Here's what we get. Routinely, I get patients that tell me they have virtually zero pain. I'm going to show you one that was, she was really nervous about having pain, and I'll explain to you why later in the presentation, but I'll go through all of that. So this is 3 months later. We take the stock abutment out. Here's a removal tool with this implant company. This is Biotech. And this is what we get, the exact replica of what the patient had originally. We use a scan body. We scan that. The lab then makes that's going to fit the exact, again, they'll fit that exact socket, the fingerprint of that patient. One mistake we made is we went a little bit too bright on the crown, but it was my dad and he didn't care. And we ended up with just a really white crown. But there is his finish product. And there is the crown in the bone. The only thing I would do different now is I want this, and we've talked about this, instead of I would have liked the abutment a little bit longer to be able to give a little bit better emergence profile. But this is what we originally started with when we did the custom healing abutment. So now our custom healing abutments have a little bit more of an S curve to allow a little bit more bone growth around the implant. But this serviced my dad very well. Okay, so here is another patient. And what this patient came in, this is going to be very similar to that KOL. In fact, the next 2 cases I'm going to show you are tooth number 19 and how I did this case. She actually came into the office today, and I took another x-ray of it so that I could show you. And so it was 25 months ago. So it was a little over 2 years ago that we did this case. But this patient came in, she is a 62-year-old female. She had pain on tooth number 19, and she had a active fistula. She had a root canal that was done 10 years previous to this. So the treatment plan was an extraction of tooth number 19. We wanted to section the roots. And so we did something kind of unique. We wanted to see if it was possible to do. And we were able to have what's called an all-in implant guide for the sectioning of the tooth. So let me kind of go through this and I'll show you how this was done. Here's the original tooth. Here's the fistula. You can see that. Tooth was in pretty bad shape. And so decided to go ahead and extract it. Here's the 3 things that need to happen for the design team: CBCT, a intraoral scan of the digital scan is ideal. You can still do it and they'll accept PVS impressions. You just have to send it to them and then they'll do the scan, but digital scanning is the way to go in my opinion. We take photos. We also send the photos just because it's good for the design team to be able to see the patient. This is what I get back from the design team. And we go through a series of these. And I wish I could show you the video from Marius. Marius is the head of the design team, and he is absolutely brilliant. But what I get is we're able to actually see the exact extraction socket and where the implant would be contacting bone, and I can see the stability that we're going to have. And in this case, we wanted it in the mesial root. We had a curve of SPE. We want to be in the mesial of the root and going right into the furcation. And so that we can, and everything, when we go through the design process, it is from the crown down. And that's how it's always done. This is what I got back from the lab. Here is our surgical guide. I also had a crown reduction guide and then a furcation guide so that we can actually go through the furcation and be able to see exactly where we are going to use a 2 millimeter guide drill so that I knew how to go through that furcation exactly. So all in means you get everything in that you need for this case. And we have guides for sinus lifts, for partial extraction therapy, anything that you potentially could use a guide for, we've used it and we're perfecting that. Here's what I get to be able to restore it. What I get is a custom healing abutment, like I showed in the first case, a final zirconium abutment, and a PMMA. And we're doing a little bit different now, but I can just show you these are the 3 components that we get. And we order this when I say I want an all-in. This is what I receive every single time. If I don't have enough stability, I can always go to the custom healing abutment. How much stability do I want to be able to finish this? I want to see 50 Newton centimeters. Up to 70 is my comfort zone, especially in the posterior. This is what I want to be able to have to be able to know that I can torque that to 25. If I don't get that, let's say I get 35, then I'm putting in the custom healing abutment. Both of them seals the socket, that fingerprint of that patient exactly. So let's go through the case. Here is our occlusal reduction guide. We remove that, the tooth exactly where it needs to be. We place our furcation guide. We then use 2 millimeter guide drills, knowing the exact depth, and this is all spelled out in your drill report. We then go to the exact depth that we have on our 2 millimeter guides. We then have our 3 holes that are made with that 2 millimeter guide drill. We then just connect the dots. We verify it with an X-ray, and we see that we went exactly the depth that we wanted to go. We remove the 2 pieces of bone, or I'm sorry, of tooth, the mesial and the distal root. And then here is my extraction socket. I mucked it up too. I grabbed this with the forceps. I was really upset at myself because I really wanted this to be a pretty sight, but I make mistakes, probably even worse than the KOL slide. But I want to just show you, it looks very similar to that KOL. And we've got papilla. We're going to be placing it in the mesial root. Here is our drill guide, our surgical guide. Then we are actually placing the implant at an exact depth, and the timing is exact in this drill guide so that we know exactly where to place it. So we know the line of the depth. So we want to see that black line, and we want to be able to see, we have 3 markers that we can verify it with. We have I would say that the mesial marker, the distal marker, and then the big black area is going to equal that area. So I want all 3 to be able to correspond. Here it is a little bit easier to see. We use the penguin. We want to be above 70 on our scale, and we've got 74. So we can proceed. So then what we do is we do our bone graft. We put the cover screw in. We do our bone graft. And then we place our final abutment, and we torque it, in this case, 20 to 25. We get an exact seal around the socket. Now, at times, if I've got a little bit of a loose area like this, sometimes I'll go in and throw one suture, resorbable suture, just to make sure that that seal is really, really tight. In this case, we didn't. But here is the PMMA on top. We want to make sure that there's no occlusal forces on top of that tooth. It's going to get minor loading, and that's what we want. But we don't want to see, so we're using a occlusal tape, and you can see I took it down pretty well to make sure that there was nothing that was actually in occlusal contact. Here is another one. This is directly to show just the papilla. And this is day 1 of surgery. Again, I've had a lot of people say you should have had this a little more distal. We can argue the correct angulation of that implant, but overall, this is where I wanted to place it, against this wall and against the interradicular area of bone. Place the bone graft. This is 3 months of healing. Here is 1 month of healing. At 3 months of healing, we can see we actually had bone growth. This is what we're looking for. Here is 1 week post-op. We see that we have, I'm sure because of the fistula and me pinching this area, we're going to get a little bit of tissue resorption. But that's okay. We can deal with that. But I'm keeping the papilla and I'm keeping this bone. And the only reason we're keeping it is because we are maintaining the soft tissue. To me, that is the key. So here is 3 months post-op. Again, 3 months post-op. Here is the before. Here's 3 months post-op. We had a little bit of resorption, so I just took a fine diamond, and I'm just going to take that down a little bit. Here is our final crown. Again, I like white crowns. Patient liked it as well. And what did she want? She goes, eventually I want to do that crown in the back. She hasn't done it, but that's why we do the make it a little bit more aesthetic. So this is the KOL slides. And if you look, loss of papilla, we gain papilla. This is basically this was today. This is the bone today. This is over 2 years. And what I was trying to show you is what the original, here you go. Here is at 1 day. This is at 2 years. Then I was showing you what the tissue looks like after 2 years. My main thing that I want to show you is after 2 years, we're maintaining papilla. We're maintaining the bone height and the buccal bone because we're able to do that. So I'm going to go pretty quick because I'm running out of time a little bit. What is the most accurate system to place dental implants? In today's world, we've got robots now. I've got right now, the doctors are telling me I need a full knee replacement. And I'm debating whether to do it. But if I was going to do it, they've got robots that can assist with the full knee replacement. It's very similar to what we do. They're going to use titanium screws, and they're going to go in and completely redo my knee. Well, the most accurate system is a robot. Do we have robots in dentistry? Yes, we have the Yomi. It is a full-on robot. And the conclusion is, they did a study. The conclusion is the accuracy in the implant placement using a robot-assisted implant surgery was comparable to that of a static guided system or a surgical guide. So it is as accurate as a surgical guide. My only issue is I actually bought the Yomi and I never took possession of it because once I looked at the fees associated with it, I just couldn't justify it. When I look at the accuracy of what I'm getting now with the design team, I actually don't think that the Yomi can be as accurate. I have a friend that uses it and he's limited on what it can do, but it still is an incredibly accurate system. X-Guide, looked at the studies associated with X-Guide. It is by far more accurate than freehand. It does work. But when we look at fully guided, the study that I found in the Journal of Dentistry says both guided and freehand implant placement techniques resulted in high implant survival. However, implant failure rates were almost 3 times higher in freehanded implant placement category. A guided implant placement approach is recommended for a successful outcome. So this is my daughter-in-law, Claire. She's pregnant. I just did this implant, let's see, last Friday. She had tooth number 19. We can see the bone. We can see that she's got great papilla. What did she have? She needed a root canal. Went in, had the root canal done. 3 months later, she has a blown out abscess, and so it did not get better. And so what did we do? Here is the planning that goes through Marius. Here is her fingerprint of her socket. This is the abutment that was planned for her. This is what is again, this is proprietary. There's no other system on the market that can give us the exact fingerprint of this other than through what Marius can do with the software. He's brilliant with what he can do. This is, I look at the implant. This is through True Abutment. Love these implants. This, we're able to design this exactly where we want to place it. Here, I'm just going to quickly go through this because I am running out of time. Because I want to leave a little bit for questions. When we look at it, remove the tooth. We section it. I didn't use a guide. I just sectioned the roots. Here is the sectioning. Removal of those roots. The hardest part of this whole process is really extracting, is the extraction process. So that I don't want to ever reflect, ever. And I want to do this with as much blood supply as I possibly can. Here is her fingerprint of socket. This is my drill guide. This is what I get from Marius. And it exactly shows me, even in picture form, exactly which drills I use and then where I finish. And so it's where I finish is exactly at that line. And I put this horizontal line or vertical line right with my markings on my drill guide. So this gives me my exact timing. This is what I have to make sure and be extremely accurate. Here is the implant placement with the cover screw. This is before bone graft. She had a big blowout of abscess. We cleaned that completely out. This is with the bone graft material. This is what I want to see. I want to see about 1 millimeter to 2 millimeters of height on my abutment. And this is the final abutment, never to be removed again for Claire. What do I anticipate? I anticipate bone growth all the way into this area. And so here's our plan. This was our execution. It is almost exact. And next time I'm going to go through and show you anterior work, a lot of anterior work we've done with partial extraction therapy, with sinus lifts, and I'll show you even in a more accurate depiction of what we're doing here. But this is, in my opinion, the most accurate way to be able to place an implant. The timing, the height, everything is pre-planned. There is the abutment in her socket. We then fill that with a specific way that we fill these things with Teflon tape. And then we use what's called clip flow, and then Admira, and then final Filtech Supreme, just to make it look better. This is a final crown. Whether we use this or we just use it as our temporary, this is a final crown material known as Grafenano. It's a new material. It is a composite material. What I like about it is the flexure strength of Grafenano is very similar to Denton, and it has the ability to withstand years of service for this implant. What I don't like about zirconium is that it is too rigid. I do truly believe that Grafenano is going to be a material of choice for us in the future. But this literally is Grafenano. This is day 1 of surgery. We've maintained the papilla. We've maintained the space. Here is day 1 of this as well. I'll have to give you an update in the future, but this is her final crown. Now, she's pregnant, 3 months pregnant. We could not sedate her. We couldn't even use laughing gas. And she was very nervous about the pain afterwards. The only thing we could use is Tylenol. Can't use ibuprofen. So I saw her the next day. My grandson had a basketball game, saw him, and basically I went up to her and said, "Okay, how are you doing?" And she goes, "I'm really concerned." And I go, "Why are you concerned?" And she goes, "Because I literally have zero pain. Is that normal?" And I go, "Well, normally you have a little bit of pain, but count your blessings." I truly believe if we can use this fingerprint principle of sealing the socket day 1 of surgery, the amount of morbidity, pain for the patient goes down dramatically. And this is what we see with our patients. I am really sorry I'm not sure what happened. Next time we'll definitely test this a little bit better and make sure that we don't have these issues. But I believe the target of anything in life should be to do it so well it becomes an art. Thank you for participating and letting me show you what I've been working on, and this is what I consider to be my art. So, any questions? We got a few minutes. I'm going to stop sharing.
I am not seeing any